Hi, everyone. Welcome to our October Journal Club for AOCPMR. My name is Nick Trevellis. I am here with my co-chair, TJ, and we are so thrilled and happy to present Dr. James Meiling of Mayo Clinic. We were lucky to have him present to us for our education committee on an EMG lecture. Today, he's going to be talking to us about imaging findings of spinal degeneration and its importance in physiatry. A little bit about Dr. Meiling. He did his medical education at Texas College of Osteopathic Medicine, and he is currently a PGY4 at Mayo Clinic in Rochester and will be doing an NMM fellowship next year. Without further ado, Dr. Meiling, take it away. Thank you so much.
Thanks. And I'll just clarify. So I'm doing a neuromuscular fellowship. So all the ALS and myasthenia gravis, all that kind of stuff with EMG. But no, you're good. You're good. The common confusion. Thanks everyone for coming out. This is an article for this journal club that we actually talked about in my residency program a few months ago. And I just thought it was so applicable as a resident that I thought it would be a good one to kind of share tonight. Because it spans all aspects. If you do general PM&R, if you do sports, if you do pain, if you do inpatient like spinal cord injury stuff, you're gonna see people with back pain, and you're gonna see lumbar X-rays forever. And so it's really important to know what it actually means and when you're looking at a lumbar X-ray. And I think this article goes over really well. So it's called. It's a systematic literature review of imaging features of spinal degeneration in asymptomatic populations. And this was actually performed here at Mayo, so this is not a biased thing at all, but it was performed here. And so that's why it came recommended originally in our journal club. And so I'll go forward here. So kind of as an introduction, low back pain is a high prevalence disease. I mean, you're gonna see it no matter what you go into in PM&R, and it affects 2/3 of adults. Low back pain is associated with high healthcare costs. It's associated with high economic consequences. For example, like if you have low back pain and you have this patient who goes on disability, then you have a loss of productivity. You have people who are taking more time off of work, which means that companies are still having to pay them even though they don't have their people there. And so it really affects kind of the American economy and everything. You're gonna see this all over the place. Now, with that being said, low back pain evaluations, oftentimes we get X-rays, but then we also sometimes get these advanced imaging, these MRIs and these CAT scans, and they're increasingly used in these evals. Patients with low back pain often have interventions done, whether medical, injections, or surgery, when degenerative changes are found in imaging, such as disc degeneration, facet hypertrophy, or disc protrusion. Sometimes, though, interventions are unsuccessful in alleviating the low back pain, and so it's important to know: are we treating the symptom itself, or are we treating the fact that they have these findings on their imaging? And so prior studies have actually show that spinal degenerative changes are associated with low back pain that are also present in a large proportion of asymptomatic individuals as well. And so this study, what the primary aim was, so whenever you're looking at a study, you want to see, why was it done in the first place? What was the point of doing it? So the primary aim of this one was to do a systematic review, and I'll talk about what that is in a second, to determine the age-specific prevalence of various imaging findings often associated with degenerative spine disease in asymptomatic individuals. And so specifically, the authors looked at these items that are underneath: disc degeneration, disc signal loss, disc height loss, disc bulge, disc protrusion, a lot of disc stuff, annular fissures, facet degeneration, and spondylolisthesis. I'm going to go through and I'm going to show you pictures of most of these things as well, so you know what you're talking about, or what we're talking about here. This study went and used MRIs instead of X-rays because of the advanced imaging that's being ordered more often. So we're going to look mostly at MRIs here. So if you look at this one, this is a sagittal view of a lumbar spine. You can see the arrow pointing there. This is an example of disc degeneration. So the discs should look, if you look at kind of the black spaces above, can you see my mouse here if I do this? So if you look at the black spaces up here, this is more of a normal, and then more normal height of what you should see. But disc degeneration is going to be this more crunched looking area here. Disc signal loss is, if you look above here, again, you see how it's kind of white in the middle here in the disc. These are more healthy looking discs. And if you look down at these ones, how you're missing that white area in the nucleus pulposus. And so then this would be some signal loss. Disc height loss is very similar. I mean, you have more healthy, I'm doing a lot of air quotes here because we'll talk about what this actually means for somebody. Healthy height as opposed to disc height loss where it's crunched down a little bit. You have disc bulges that happen where the disc itself is just kind of getting out into the area where the spinal nerves live. Sometimes if it's up higher, where the spinal cord lives. And disc protrusions where it goes out even further into that area. You got facet degeneration. So this, instead of looking at a sagittal view, this is more of an axial view. So this over here is the left side of the body. This is the right side of the body. You kind of view it as if somebody's laying down on their back and you're looking from their feet up to their head. So this is pointing to the right side over here. These are facet joints. And so it is the joint between the top vertebrae and the bottom vertebrae where they sit and hit one another. Sometimes when physicians, particularly when, for example, pain physicians are looking to see, should we do a facet injection, they're looking to see if you have facet edema in these joints. And so that's what the white is in between there. And they sometimes look to see if the facets are hypertrophied or bigger, just like if you were to look at arthritis anywhere else in the body to see if it was bigger. And then spondylolisthesis, that just refers to the fact that a vertebral body sitting one on top of another, instead of being directly on top, as you would expect in like a normal spine, you'd have this one that is slightly either anterior to where it should be or posterior to where it should be. So these are all findings that you can find on any MRI, whether the patient is in pain and having symptoms or whether they're asymptomatic. So for this particular study, they performed a systematic review. So systematic review, there's lots of different kinds of reviews, but systematic review is where you have a very set approach to how you are searching for different articles to review. Oftentimes you use a librarian who is trained in how to perform these type of reviews. And they use multiple databases to gather all of the articles associated or even remotely associated with what your question is. So in this case, they used this search and got three databases, or they used three databases to get these articles. Now, from someone who's performed some systematic reviews, I personally think three databases is a little small. Usually databases, when you're doing this, I've seen up to 8 or 10 different databases used, so you get a much wider breadth of articles. So I personally, just from there, I think it's a little small. And then studies identified from the lit search further evaluated for inclusion in the meta-analysis, so the ones that they're going to use in their kind of summary at the end. They said in their article, we also searched references from multiple articles to find any additional studies. I thought that was interesting because the word multiple there, how do we know which articles they're using to find more studies? Did they miss anything? Did they only search in 10 out of the 100 that they got back? And so it's important to see what the authors actually mean from here. So study selection. So after you perform this search, you want to know, as you're going through all the articles you get back, what your inclusion criteria and what your exclusion criteria is. So which articles are you going to keep in, and which things actually kick the articles out and won't make them a part of your review. So their inclusion criteria was the studies had to be in English. And then they had to report the prevalence of degenerative findings in different age groups on spine MRI and CT scans in asymptomatic patients. And so asymptomatic, they defined as no history of low back pain. So their exclusion criteria, if any of the patients reported in these studies had minor or low-grade low back pain, then they were excluded. If the patients had motor or sensory symptoms, tumors, or trauma, they were excluded. And then if the article itself did not explicitly state that these are pain-free individuals, then it was excluded from their study. So they used 11 reviewers, and they examined the abstracts from the lit search. So they got this whole big list back, and they went through and with these 11 reviewers, and they were able to look at every single abstract they got back. And then all the articles evaluated by 2 reviewers, so in duplicate. That's really important because that helps to eliminate some of the bias, and also helps to make sure that nothing is missed. And so that means that, say they got 100 articles back, all those 100 articles were reviewed by 2 individuals. So then you have the data extraction form was used to get following information. This is important as well. The data extraction form is usually like an Excel document that the article or that the authors have previously laid out that says these are the things we're going to take from each of these articles that we get back. That way they have a good comparison and they can compare back and forth between different articles. So they used an imaging technique, or they got the imaging technique, the age-specific sample sizes, and then the prevalence rates for each of the degenerative findings listed previously that we talked about. So then from there, they did a data synthesis and analysis. And they said that for each imaging finding, we fit a generalized linear mixed effects model for an age-specific prevalence estimate, a binomial outcome, clustering on study, and adjusting for the midpoint of the reported age interval of each study. That is a mouthful. This is their statistics. This is what they did to compare across studies. And I think it makes more sense when we actually look at the results itself to know what they're talking about here. So we'll kind of skip ahead to that part when we to talk about that more. So whenever you do a systematic review, you always see a chart like this. This chart lays out kind of the stepwise approach. So when they performed the review and they got, or the search, and they got all the articles back, they got 379 articles back. Now, you'll see from here, you drop from 379 to 79 full text articles retrieved for more detailed evaluation, and 300 were excluded based on abstract and title alone. That means they went through the title and the abstract and it didn't meet the inclusion criteria, or it met the exclusion criteria, so it got kicked out. So you're left with 79. Then they went through the full text articles, kicked out 21 of them, and had 58 potentially relevant articles left. These 21 were excluded for either not including adult patients, reporting findings that that were not included in the current analysis, like Schmerl's nodes, which are a kind of another asymptomatic finding you can have on these imaging, or no separation between symptomatic and asymptomatic patients. And it's kind of hard to talk about just asymptomatic patients if there's no separation between those with symptoms and those without, so they had to exclude those articles. And then finally, they narrowed down another 25 to 33 articles with usable information for the study. The 25 they excluded was due to lack of age-stratified outcomes. They had a mixture of symptomatic, asymptomatic, and mild pain patients, or reported outcomes by level rather than by patient. So as you can see, whenever you do a systematic review, you start with this big old honking number of 379, and usually you whittle it down to just the relevant articles. So for them, it was 33. So what happened in the study? So you had 33 studies that met the reporting imaging findings for ultimately 3,110 individuals. That is the total number of individuals within these 33 studies that met the inclusion criteria. 32 of these studies reported degenerative changes on MRI, and 1 reported degenerative changes on CT scan. So majority of them were MRI. And the sample sizes in these studies were anywhere from 8 people in the study to 412 in the study. So what happened? I think that the tables in this were the most revealing personally. So if we look at this first table, the title of it is called Estimated Number of Patients by Age Used to Inform Prevalence of Degenerative Spine Imaging Findings in Asymptomatic Patients. So what that translates into is, in these studies, if you were looking, for example, at disc degeneration, people who were in their 20s made up 273 people in these studies. People who were in their 30s that had disc degeneration made up 604, etc. So this table, I mean, gives us just kind of generally what the patient population is. This one, I think, is the better of the two. So these are age-specific prevalent estimates of degenerative spine imaging findings in asymptomatic patients. So if we look down the left side of this table here, you have the imaging findings, you have disc degeneration, disc signal loss, etc., that we talked about before. On the top here, you've got the age ranges, so 20, 30, 40, 50, 60, 70, 80-year-olds. Excuse me. And then the percentages here are the percent of patients in this age group that showed these findings. And to remind you, these patients are all asymptomatic. No pain, no low back pain, no pain whatsoever. So disc degeneration. So I'm assuming we have at least a few people on this call who are probably in their 20s. 37% of the people they found here who are in their 20s had disc degeneration. And as you go up in age, you'll see that a higher and higher percent until, if you're looking at people above 60 years old, you've got a good chance, 88% or more, that these people are going to have disc degeneration findings and they don't have any pain. You look down then at the next one, disc signal loss. Again, you see that same kind of stratification. The higher in age you go, the higher likelihood is that you'll have these findings on MRI, but you won't have any actual pain symptoms associated with this. Disc height loss is the same as you go up. Disc bulging. Disc protrusion is interesting because it's about the same across the way. I mean, it gets slightly higher. It's only about a 14% difference though between the 20-year-olds and the 80-year-olds. Annular fissures, slower increase. Facet degeneration though, I mean, look at this. As people go up in age, this goes up higher and higher, faster and faster, which makes sense because as people get older, they have more of a chance of having degenerative joints. I mean, we see that in knees, we see that in hips, but that doesn't always translate into, ow, I have knee pain, ow, I have hip pain, ow, I have back pain, which is why we treat patients and we don't treat images necessarily. Now, if patients have symptoms, then the images can help us know how to treat them. But you don't treat asymptomatic patients, that would be crazy. And so then the same thing with spondylolisthesis here. As you can see, as people get older, there's more of a chance that you find these. So the discussion goes then over the summary of the results. So this systematic review indicates that many imaging findings of degenerative spine disease have a high prevalence among asymptomatic individuals. I think we can agree from that last table that that's true. All imaging findings in the systematic review increased with prevalence with an increase in age. Some of them increased faster than others, and some of them were more prevalent than others. I mean, if you look back at this other chart, disc degeneration, disc signal loss, facet degeneration, these things are all in the 80s or 90% once you get up to 70 and 80-year-olds. Some findings present in 90%, or at least 90% of greater than 60-year-olds. And then degenerative imaging findings are generally part of the normal aging process rather than pathologic process requiring intervention. This is more of a conclusion that they came to based on their studies, that you're gonna find degenerative, you're gonna find degeneration in the spine, whether someone has pain or not as they get older. It doesn't necessarily mean that they have pathology present. The rest of the discussion in the article, the next two paragraphs, then gives a lot of other examples in the literature regarding imaging findings in asymptomatic individuals, an increase in imaging findings with an increase in age, and then states a few studies that found increased imaging findings in patients with low back pain. So pretty much the same thing. So every study you read, even the best laid studies will have limitations. And so some of the things that we found with this study is that, first off, the selection bias. All the participants in the study were volunteers. And so it might not necessarily be representative of the general population. It just represents the people who actually volunteered for the study itself. But they also did have about 3,000 people between the 33 studies. So kind of take that as you will. Then publication bias. They only use 3 databases. And it's possible that if they'd used more databases, they might have received more articles back, more studies back, that would have possibly changed the results a little bit. Other limitations is they only had one observer. So many of the studies use one observer rather than multiple to comment on the degenerative changes on the MRI. That means that the people actually reading the MRIs, it was all done by the same person in a lot of these studies. And so instead of having two people then comments on the fact that, oh, there's facet degeneration on this one and facet degeneration on this one, it was all done by one person. So it's kind of hard with that to ascertain whether there's, if there's observer agreement, because there's only one observer present. Recent studies, so even with standardization of nomenclature, inter-observer variability is moderate at best. And that's just what recent studies have said for other things like knee and hip. Non-standardization of nomenclature was used. So this was, this study, or this systematic review ended up using studies that were in a 25-year span. And so it's possible that how facet degeneration was labeled on prior imaging was different, or how disc signal loss or disc height loss was used was slightly different, but we don't know. This is just a possible limitation. And then finally, it is possible that asymptomatic individuals have less severe degenerative changes than symptomatic individuals. This study didn't look at symptomatic ones, so it's hard to say, like, if I had back pain and the guy next to me did not, what our backs, how different those would actually be one to another. So this study, so it doesn't imply that the above mentioned degenerative findings are always age-related rather than pathologic. It's just we didn't look at symptomatic ones at all for this study. So their conclusion. So it's important whenever you're looking at conclusion to make sure that it's clearly stated and can't be backed up with what the rest of the study actually talked about. You'll find that some papers you read, the conclusion won't be backed by anything that they actually studied in their actual review. So it's important to kind of go back and see. So the findings on this suggest that many imaging-based degenerative features may be part of a normal aging process and unassociated with low back pain, especially when incidentally seen. So it's important to kind of interpret these findings in the context of patient's clinical condition. So real life application. This is, I think, one of the most important questions whenever you're doing a journal club or a review, or even just when you're reading an article itself, is, does this apply to me? How will this actually change my practice? Does this matter for me? So I think with this question, and I want to hear from y'all as well, but I'll kind of start. For me, I don't plan on seeing a whole lot of back pain in the future. I know that it will happen, but just with the type of practice I'm going into, I don't foresee it pertaining completely to that. But if you're going into general PM&R, if you're doing sports, if you're doing pain or interventional spine or anything like that, you're going to be seeing a lot of back pain. I mean, it's very prevalent. And so it's important to kind of realize as you're seeing these patients and they come in, it's important to realize, does what I'm seeing on the image correlate with how the patient's feeling? For example, if you have a patient who comes in and they've got pain going down their legs, but really no back pain, and you look at their image and they've got facet degeneration, like, if it's going down their legs, it sounds a little more radicular in my mind, and this is just according to James, but it sounds a little more radicular. And so I wouldn't treat their axial mechanical facet changes. I would try and treat their radicular symptoms. Now, if you have someone come in and they have back pain that is located just in the back, and it seems to be just in the back as you're doing all of your physical exam, and there's not radicular signs or weakness or anything like that, and then you look at the image and you see, oh, they've got some degenerative changes, oh, they've got some arthritis in their low back, then maybe it would be appropriate to treat that area. But in PM&R especially, like, we treat the patients that we see, we treat the symptoms that we see them come in with, and we don't treat just what the image itself shows. I think you'll find as you continue in your training, as you go to residency, as you go to fellowship, or you go into practice, that there are going to be very, very many different people who practice different than you and different than maybe your training was. Some for better and some for worse. But I would encourage you to not fall into the trap of treating people just to treat people, but to treat people because this is how I feel I can actually help this person benefit. And I have the physical exam, the imaging, the EMG, whatever it may be, I have this to back up why I'm treating them the way that I am. And I think you'll do a lot better by your patients that way. And you'll be a better doctor that way as well. So that's just my 2 cents. Did anyone else have any other thoughts or anything while we were kind of going through this article, or things that you might have experienced that you have questions on or anything like that?
I really appreciated you walking through the transverse cut and like pointing out the facets, because that's definitely been something that I've seen like plenty of times, especially on PM&R rotations, and like never was walked through that type of imaging before. And so like you doing it at the beginning was just incredibly helpful, in addition to discussing the article. But like, I just wanted to mention that was incredibly helpful. So thanks for taking the time to do that.
Yeah, no problem.
I was really surprised by how many people have degenerative changes and no symptoms. That's something I kind of have personal experience with. I used to be like really big into competitive weightlifting. And there was a time where I was doing a pretty like heavy deadlift, and I was rushed through my warm up, and it kind of felt like a hot knife was like stuck in my back. And I started having like shooting pains down my legs. The next day I was at work, I took my blood pressure. It was like 180 over 120. And I was in like some serious pain, but it went away over time. And I talked to my PT and I was like, hey, do you think I should get this looked at? And he actually said not to get imaging because a lot of, and like, I don't know if this is actually something that you would agree with or not, but he did say that I shouldn't get imaging because a lot of people get pictures of their back and then they see all these degenerative changes, and then the idea gets in their head, and then they start babying themselves, and they're like, oh my God, I have all these degenerative changes, like my back is ruined, and they stop living life the same way that they normally would have out of fear. So I don't really have any issues today, and I feel fortunate that I got away with that. But yeah, it's just interesting insight.
Yeah, and don't get me wrong, imaging is not necessarily a bad thing. I mean, I use imaging with most of my patients as they come in. But I think that the proper application of imaging is what's key. I think you'll see, as if you haven't already, you'll see people who come in who have had an image done, and they might get stuck on the littlest thing on their image and say, that's it, that's the cause of what I'm feeling and my pain. Whereas you, as this PM&R doc who's since had this training and everything, you know that really that what they're seeing there doesn't really, not to say it doesn't matter, because you want to help the patients to understand what's causing it, but the image itself, that finding might not be the cause of their pain. We see that pretty often with patients who come in, usually older patients who their knees really hurt, right? And so their knees really hurt, and they got this imaging done on their knees because it just hasn't gone away, and they see that, oh, I've got a meniscus tear. But I hate to break it to you, people over a certain age, especially if they have arthritis in their knees, they're going to have degenerative tears in their meniscus. And most likely, you're not going to find a lot of orthopedic surgeons who are going to go and actually intervene on that, because the degenerative tear, it's different than a traumatic tear or in a younger individual. And so, I mean, we start with our roots here. We start with the rehab of things. You start with physical therapy, and if physical therapy doesn't work, then you try some other things with it. One thing that I have a mentor here at my institution at Mayo, who says that really there are 5 things that in kind of the MSK world that we can do and to help treat people. The first thing is therapy. So if you have someone who comes in with, no matter what the musculoskeletal complaint is, like, you can try physical therapy with them. And then I've heard variations of this now, but you have topical, you have oral, you have injection, you have surgery. And then sometimes the best thing to do is just to do nothing on it, because it'll just go away on its own. They've shown in some studies that that lumbar radiculopathy, so a pinched nerve in the back, that it's a high percentage, and I'm going to probably get the percent wrong, but it's up to like 80% of them go away on their own. And that there's a smaller amount that actually stay long enough that we need to do all the advanced imaging or go the injection route. So it's just something to kind of consider, is that sometimes the easiest thing to do is just to say, here, work on the physical therapy, work on the strengthening, the stretching, making sure your gait's okay, and things tend to work themselves out a lot of the time. Any other thoughts from anyone?
I was just going to say that goes back to the core of what we do, right? Function is key. And so if you work on the function, you improve the function, things can generally help and improve themselves over time. And as DOs, we also know the body has the ability to heal, and structure and function are interrelated. So all good things, all just fun to reflect upon. Fantastic journal club. My question was, in interpreting the data and looking at it, I noticed that they did their regression model. It was a linear modified regression model. So did that take into account also other like comorbidities that the patients also had, and the different other characteristics about patients in addition to age, if gender played a role in anything, if socioeconomic status and access to health played a role in any of that? I'm just a little curious about how to think about those factors in addition to looking at this data and interpreting it.
That's a great question, because usually those things do come into play when you're looking at these. I do not remember, to be honest, when I was looking through the article, whether they looked at all those things. Now, if you were to look at individual studies from the systematic review, so of the 33, I'm sure that those, many of them, went into all those. But I don't remember them specifically reporting that in this systematic review itself.
Just another thing to think about when kind of pulling all the data. Of course, they had thousands of patients that they looked at, so they're likely, because of the large N, because of the way the systematic review covered it all, it probably was able to take care of a lot of those things. But just other things that I like to think about when I'm assessing this. But thank you.
Yeah, well, and it's important to realize too, in a systematic review, when you're doing a meta-analysis, in order to compare study to study, you have to have the same types of things looked at across the different studies. So if one study, for example, did a linear regression model and looked at gender, say 20 of them looked at gender, but 13 did not, then it's kind of hard to do a meta-analysis of that factor of it, because it's not consistent along the way. When you're doing a systematic review, you can do a meta-analysis, and usually, if you are able to, you should. But if you're not able to, because the articles differ enough in between the articles, you can actually do more of a narrative approach to a systematic review and still report things like the risk of bias, and the certainty in evidence using like the grade approach, which is a whole nother topic. But you can certainly use those things to kind of help solidify how biased these articles are, and how much it truly says what it says.
Thank you.
Yeah. Well, those are my references. I'm happy to stay on for a few more minutes if anyone else has any questions or thoughts, but that's kind of all I got tonight. I like to make things kind of short and to the point. So
fantastic overview of spinal imaging, and great exposure for all of us, either while we're on or before we get to PM&R rotations. The floor is open if anybody has any questions. We have some thank yous coming into the chat. Again, we are so lucky to have you, Dr. Meiling. This has been yet another great lecture for AOCPMR from you. So we are so grateful. Thank you so very much.
yeah, absolutely. Absolutely.